Welcome. This first lecture is on the integumentary system, which is the skin and its accessory structures. We start here for a reason. The skin is the largest organ in the body. It's the first thing you observe on every patient, and it gives us an ideal place to establish the pattern we will follow for all 14 body systems this term. Each system is taught in 3 short lectures. Lecture 1, which is today, covers anatomy, physiology, and how the system changes across the lifespan. Lecture 2 will cover pathophysiology, diagnostics, and pharmacology. Lecture 3 focuses on the medical assistant's role. In this first lecture, our goal is foundational. We will build the vocabulary and the structural picture you need before we ever talk about disease or medication. By the end, you should be able to picture the layers of the skin, name what lives in each layer, explain what the skin actually does for the body, and describe how newborn skin and older adult skin differ from the skin of a healthy young adult. Keep in mind that everything we cover connects back to your daily work. Skin assessment, wound care, specimen collection, and accurate documentation all start with the anatomy we're about to review. Before we get into the material, here's our roadmap. These are the 5 things you should be able to do when we finish. First, identify the 3 primary layers of the skin, the epidermis, the dermis, and the hypodermis, and describe what each one does. If you can only remember one visual from today, make it that 3-layer stack. Second, describe the accessory structures, hair, nails, and glands. These grow out of the skin and each has a specific job. Third, explain the major physiologic functions of the integument. The skin is not just a wrapper. It protects, it regulates temperature, it senses the world, it helps make vitamin D, and it helps balance fluid. Fourth, summarize how skin changes across the lifespan. Newborn skin and older adult skin behave very differently from the skin of a healthy young adult, and those differences change how we handle and assess our patients. And fifth, connect all of this to your role as a medical assistant. Anatomy is not trivia here. It's the reason we position, protect, and document the way we do. Keep these outcomes in mind as we go, because the summary at the end will circle right back to them. Here are the medical terms that you need to know to understand this lesson fully. Take a moment to look them over. Pause the video and take as long as you need to take your notes. We'll use each of them as they come up in the slides ahead, so don't worry about memorizing the definitions right now. Just familiarize yourself with the words. Let's establish the big picture. The skin is the largest organ of the body. Laid flat, it would cover roughly 2 square meters in an adult, and it forms the boundary between everything inside you and the outside world. That boundary role is the theme that ties all of its functions together. Structurally, the skin is built in 3 layers, shown stacked here on the right. On top is the epidermis, the thin outer barrier you can actually see and touch. Beneath is the dermis, a thicker layer packed with blood vessels, nerves, and glands. And deepest is the hypodermis, made mostly of fat and connective tissue. We'll take each of these one at a time in the next few slides. Growing out of these layers are the accessory structures, hair, nails, and glands. They aren't separate organs, they're specialized products of the skin. Functionally, keep 5 jobs in mind: protection, temperature regulation, sensation, vitamin D synthesis, and fluid and electrolyte balance. And here's the connection to your role. Because this is the first system a patient presents with, you see their skin before you see anything else. Your observations about color, integrity, moisture, and temperature are often the first data point in the visit. That's why we start the whole course right here. Now let's go layer by layer, starting at the top with the epidermis. Remember that key vocabulary word, avascular. The epidermis has no blood vessels of its own, so it receives its nutrients by diffusion from the dermis below. Its tissue type is stratified squamous epithelium, meaning many flattened layers of cells stacked on top of one another. Those layers, or strata, are shown on the right. In most of the body, the epidermis has 4 layers. In thick skin, like the palms of the hands and the soles of the feet, there's a 5th, the stratum lucidum. From the surface down, they are the corneum, lucidum, granulosum, spinosum, and basal. A simple memory device is come let's get sunburned. Of course, don't do that. The 2 cells to know are keratinocytes, which make keratin, the tough protein that waterproofs and strengthens the surface, and melanocytes, which make the pigment melanin. There are also immune cells and touch-sensing cells living in this layer. 2 ideas tie it together. The outermost stratum corneum is made of dead, flattened, keratin-packed cells. That's your waterproof barrier and your first line of defense against pathogens. And the whole layer is constantly renewing itself from the bottom up. New cells are born in the stratum basal, mature as they rise, and are shed from the surface roughly every month. Moving down, we reach the dermis, the thick, living workhorse of the skin. It's connective tissue, and it attaches to the epidermis above along a wavy border called the basement membrane. Those waves matter. They increase the surface area between the 2 layers and help lock them together. The dermis is where the skin gets its mechanical properties. 2 protein fibers are responsible. Collagen gives strength and resists tearing, and elastin gives flexibility and lets the skin snap back after you stretch it. When we get to the aging slide, remember these 2 names, because their decline is exactly what produces wrinkles and fragile skin. The dermis is also crowded with working parts, blood vessels, nerves, and their sensory receptors. Hair follicles and both sweat and oil glands all sit here. And critically, because the epidermis above has no blood supply of its own, it's the dermis that feeds it. Nutrients diffuse upward from these vessels. The dermis has 2 sublayers shown in the cards below. The papillary layer is on top and is thin and loose, with those finger-like papillae projecting up into the epidermis. The reticular layer beneath is thicker and denser, packed with collagen and elastin, and it houses most of the vessels and glands. Papillary is thin and up top, reticular is thick and deep. The third and deepest layer is the hypodermis, also called the subcutaneous layer. The name tells you exactly where it is, sub meaning below, cutaneous meaning the skin. Structurally, it's mostly adipose tissue or fat tissue, along with connective tissue that anchors the skin down to the muscle and bone underneath. It does 4 jobs worth remembering, shown across these cards. First, insulation. That layer of fat traps heat and helps hold your core temperature steady, which is why losing it, as older adults often do, makes people more vulnerable to cold. Second, energy storage. Adipose tissue is the body's long-term fuel reserve. Third, cushioning. It's padding, absorbing shock and protecting the structures beneath it from mechanical trauma. And fourth, this one is directly clinical for you. The subcutaneous layer is a standard site for injections. Subcutaneous or sub-Q injections deposit medication into this fatty layer where it absorbs slowly and steadily. Insulin and many other medications are given this way, so understanding what's in this layer helps you understand why we pinch, angle, and site these injections the way we do. So the three-layer stack is now complete. Epidermis on top, dermis in the middle, hypodermis or subcutaneous at the base. The skin's accessory structures grow out of the layers we just covered. First are the hair and nails. Both are made largely of keratin, the same tough protein that hardens the surface of the epidermis. Hair grows from follicles that are rooted down in the dermis. We tend to think of hair cosmetically, but it does have real functions. It helps protect and insulate. It filters particles away from openings like the eyes and nose and ears. Think of eyelashes and the fine hairs in your nostrils. And it supports sensation because movement of a hair is detected by nerves wrapped around its follicle. Each follicle also pairs with a small sebaceous gland that keeps the hair oiled. Nails are hard plates of keratin sitting over the tips of the fingers and toes. Their main job is protection. The fingertips are packed with sensory nerves and take constant use, and the nail is a hard shield over that very vulnerable tissue. Nails grow continuously from the nail root or matrix. Here's the basic anatomy. The nail plate is the hard visible part. The nail bed is the skin underneath. The cuticle is the seal at the base, and the lanula is the pale half moon. Here's why this matters clinically. Nails and hair are windows into the body. Spoon-shaped nails can suggest iron deficiency anemia. A bluish nail bed can suggest poor oxygenation. Brittle hair or nails can point to nutritional or thyroid issues. When you take vitals and room a patient, these are quick, free observations worth noticing and documenting. The third group of accessory structures is the glands, and there are three types to know. Sebaceous glands on the left produce sebum, which is an oily secretion. Sebum lubricates the skin and hair, helps waterproof the surface, and has mild antimicrobial properties that support the skin's barrier. When these glands overproduce or become blocked, you get the acne that we'll discuss in the next lecture. Sweat glands in the middle come in two kinds. Eccrine glands are the widespread ones all over the body. They release watery sweat onto the surface, and as that sweat evaporates, it cools you down. This is the heart of thermal regulation, and it's most active during heat and exercise. Apocrine glands are located mainly in the armpits and groin. They become active at puberty, and their secretion, once broken down by skin bacteria, is what produces body odor. The third type, ceruminous glands, are actually modified sweat glands found in the ear canal. They produce cerumen, also known as earwax, which traps dust and debris and protects and lubricates the canal. That's a nice preview of the special senses coming up later in the course. So notice the pattern: oil to lubricate and protect, sweat to cool, and earwax to guard the ear canal. All three are the skin actively doing its protective and regulatory work. Okay, so we've built the structure, so let's talk about the function. The skin is doing 5 major jobs at all times, and every one of them traces back to that theme of being the boundary between the inside and the outside of the body. Protection is the headline. The skin is a physical barrier against pathogens trying to get in, against ultraviolet light. That's what melanin helps shield you from, against chemicals and against mechanical injury. It's your first line of immune defense. Thermoregulation is second. When you're hot, dermal blood vessels dilate to release heat, and sweat glands pour out fluid to cool you by evaporation. When you're cold, vessels constrict to conserve heat. The skin is your body's thermostat surface. Third is sensation. The dermis is full of receptors that detect touch, pressure, pain, and temperature, constantly feeding information to the nervous system. Fourth, vitamin D synthesis. When sunlight hits the skin, it begins producing vitamin D, which is essential for calcium absorption and bone health, connecting us to the skeletal system we'll discuss in the next section. And fifth, fluid and electrolyte balance. That waterproof stratum corneum keeps you from evaporating away, and controlled sweating helps manage water and electrolytes. Protection, temperature, sensation, vitamin D, and fluid balance. 5 functions from one large organ. One of our recurring threads all term is how each system changes across the lifespan, so let's look at the two ends of that spectrum. We start with the newborn and young child. A newborn's skin is thinner and more fragile than an adult's, and its barrier, the protective stratum corneum, is still immature, especially in premature infants. That makes the skin easier to injure and less able to keep pathogens out. Newborns also have a high ratio of surface area to body mass. A lot of skin surface relative to a small body means they lose heat and fluid quickly, which is why we bundle infants and keep the room warm. Their thermal regulation is still developing. They can't shiver effectively, and they have limited ability to sweat, so they depend on us to protect their temperature. Because that barrier is thin, newborn skin also absorbs substances applied to it more readily than adult skin, which is why we're cautious about what we put on an infant's skin. The takeaway for your practice: handle infants gently, keep them warm during exams, expose only what you need to, and observe the skin carefully. Newborn skin gives you a lot of information, but it also needs a lot of protection. Now the other end of the lifespan, the older adult. Almost every change here is the mirror image of what makes young skin resilient, and these are changes you will see on patients every single day. The epidermis thins, and that wavy dermal epidermal junction we discussed earlier flattens out. A flatter junction means the layers separate more easily, which is why older skin tears and blisters with less force. Remember collagen and elastin from the dermis slide? Both of those decline with age. Losing collagen and elastin is exactly what produces wrinkles, sagging, and reduced elasticity. The skin no longer snaps back the way it did. The subcutaneous fat layer thins too, so there's less insulation and less cushioning. That's why older adults are more sensitive to cold and bruise or injure more easily over bony areas. The glands become fewer and less active, so the skin gets drier and the body cools itself less efficiently, raising the risk of overheating. And overall cell turnover slows, which means wounds heal more slowly and bruises appear easily and linger. For you as a medical assistant, this translates directly into practice. Use gentle technique, watch pressure points closely to prevent skin breakdown, be alert to poor wound healing, and never dismiss a bruise or slow healing area on an older patient. In summary, here are 5 points capturing everything from this lecture, and they map right back to the learning outcomes we set at the start. 1. The skin is the body's largest organ, and it's built in 3 layers: epidermis on the surface, dermis in the middle, hypodermis or subcutaneous at the base. If you can redraw that stack from memory, you're in good shape. 2. The accessory structures: hair, nails, and glands. These grow out of those layers and carry out real work, from protection to sensation to cooling. 3. The skin performs 5 core functions: protection, thermoregulation, sensation, vitamin D synthesis, and fluid balance. 4. The skin changes across the lifespan from thin and fragile newborn skin to the thinner, drier, slower healing skin of the older adult, and those differences change how we handle and assess each patient. And 5. All of these fundamentals are the foundation for your everyday work, assessing skin, handling patients safely, and documenting accurately. In the next lecture, we'll build on this to cover the things that go wrong with the skin, the pathophysiology, along with diagnostics and medications used to treat them. Here are the references used for this lecture. Feel free to check them out to get more information on areas that you are interested in.